Hello everyone, this is Dr. Tanya. I am a high-risk pregnancy consultant. Today I will be talking about the diagnostic considerations while we are testing a pregnant female for syphilis. So there are three important points which I want to discuss with all of you. The first important point is the difference between the treponemal and the non-treponemal tests. See, as we all know that there are two main tests like treponemal and non-treponemal tests, but how exactly the two differ? Non-treponemal tests are basically the screening or the monitoring tests. So when I talk about monitoring, I mean when we are monitoring the response to the treatment. Whereas the treponemal tests, they are the confirmatory tests. The second important point is that when the result of non-treponemal test comes, it comes as either reactive or non-reactive. If it is reactive, it has to be diluted to establish the titers. Whereas in case of treponemal test, the result is either reactive or non-reactive. And if it is reactive, it will remain reactive endlessly, means indefinitely, regardless of the treatment. In case of non-treponemal test, once we have established the titers, after giving appropriate treatment, the titers do come down, but it may take few months to even years. That is the first important point, the difference between the treponemal and the non-treponemal test. Now, the second point I want to discuss is about the titers of the non-treponemal test. See, the titers can be 1:1, 1:2, 1:4, 1:8, 16, 32, 1:64 and so on. Now, if we have given appropriate treatment, there should be a fourfold decline in the titers. If you think that the treatment was adequate, so fourfold decline in the titers should be there. Second important point is that if you have checked the titers with one method, while monitoring the response, please do not change the method. For example, initially if you have checked it with RPR, please do not change this to VDRL or some other method because there is a difference in the titers. See, RPRs are usually 1 to 2 titer dilutions higher than VDRL and possibly 3 titer dilutions higher than USR. Means if the initial titer was 1:32 on RPR, with the same sample, the titer for VDRL will come as 1:16 or 1:8. And for the same sample, the titer for USR will possibly be 1:4. So please do not change the method. The third important point I want to discuss is that there are two screening algorithms. One is the traditional algorithm which we use, we all use. The second one is the reverse sequence algorithm. Now, what is this traditional syphilis screening algorithm? This is wherein we first test the patient with a non-treponemal test. If that comes out to be reactive, we have to confirm it with a treponemal test. Now, why we have to confirm it with the treponemal test? See, the non-treponemal tests, they are not very specific. They are less sensitive in the early and latent syphilis, and they have high false positive results. So they can be positive in so many other conditions like connective tissue disorders, like autoimmune diseases like hepatitis, chickenpox, mumps, measles, malignancy, and so on. So we cannot trust them. We have to check it with a confirmatory test, and that is a treponemal test. The second one is the reverse sequence algorithm. Now, in this reverse sequence algorithm, you first have to go for a treponemal test, that is a confirmatory test, and usually the first one which we go for is the EIA or the CLIA IgG. If it comes out to be reactive, you have to recheck it with a quantitative non-treponemal test. If that also comes out to be reactive, then you can go for the titers and like that you have to go. And if this non-treponemal test comes out to be non-reactive, you have to reconfirm it with a second treponemal test, and that second treponemal test usually is TPPA, that is treponema pallidum particle agglutination, and that is nowadays the recommended confirmatory test. So this is how you have to go about in a case of syphilis when you are checking this in pregnancy. One important point, the last point which I want to highlight is that, as I told earlier, the treponemal tests usually, once they are reactive, they will remain reactive indefinitely, except for TPPA. Now there have been studies wherein 11 to 13% of cases they seroreversion occurred in case of TPPA, and those were the cases where syphilis was found with HIV. So that's all. Thank you.